Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is Seamless MD CEO, Dr. Joshua Liu. Today, we're joined by our very special guest, Dr. David Houghton. Dr. Houghton earned his medical degree from the Medical College of Georgia and his master's in public health and epidemiology from Emory University. He completed his internship, neurology residency, and movement disorders fellowship at the Hospital of the University of Pennsylvania in Philadelphia. After then serving as the assistant professor and neurology residence program director at the University of Louisville, Dr. Houghton joined the staff at Ochsner Health in 2012 as the chief of the Division of Movement and Memory Disorders and vice chair of the Department of Neurology. Since 2016, he has also served as the medical director of Ochsner Telemedicine, harnessing technology to create unique virtual clinical connections between Ochsner's providers and patients across the Gulf South. In 2019, his role expanded to help drive remote patient monitoring as medical director of Ochsner's digital medicine. He is proud to lead the nationally recognized HDSA Center of Excellence at Ochsner Health, serving Huntington's disease patients from across the Gulf South. Dr. Houghton has been awarded System Physician of the Month, Top 75 Physician, and Neurology Teaching Faculty of the Year. He's also studied further with the Health Management Academy Physician Leadership Program in 2018 and Harvard Business School Consortium for Community Health in 2020. Dr. Houghton is board certified in neurology, and his publications have appeared in peer-reviewed journals, an online medical text, a patient resource from the National Parkinson's Foundation, and a textbook on deep brain stimulation for Parkinson's disease. Dr. Houghton, David, welcome to the show.
Thank you very much. Thank you both for having me. It's an honor to be here.
Amazing. We'll have to dive deep into some of the deep brain stimulation work that you're doing, but maybe we'll save that for another episode, because today we do want to focus on some more recent digital endeavors that you're doing. You know, David, we are super excited to bring you on the show today. You've been involved with digital care for a number of years, decades now. I think first your involvement was with Ochsner Health's telehealth program with pediatric cardiology patients way back in the day. And then more recently launching Ochsner's Connected Health program in 2018. But prior to getting involved in all this digital care, your focus was on neurology as the chief, as I mentioned in the bio, of the Division of Movement and Memory Disorders. And I have to imagine that there's some sort of link there between neurology and your patients and how you got involved with digital and you know, really how that came to be. So I was curious to start the conversation. What was your aha moment that really started this journey into digital health?
Well, thanks very much. And it has been an aha moment, and several of those moments over the last more than a decade at this point. You're correct. You know, Ochsner's journey into virtual health really did start with virtual echocardiography and other pediatric cardiology programs. But I have to say that even predated my arrival there 10 years ago, and those programs were there more than 20 years ago. So very proud to have joined an organization in 2012 that had already been a cut above in many aspects about the ways that virtual care could reach particularly vulnerable patient populations across the Gulf South. But you're right, when I got here 10 years ago, I was really focused on growing clinical excellence and efficiency and research trials and helping my colleagues in neurology. I was the 10th neurologist hired in our organization, and now we have more than 50 in our neurology group, more than 100 practitioners between neurology, neurosurgery, neurocritical care, and others in the neurosciences. And so as our clinical care was growing, I was similarly fortunate to get to work with my original chairman there, Dr. Ken Gaines, and what he was doing in telestroke. And as they were building more telemedicine programs around that. And when he eventually left and was replaced by our current chair and my friend and colleague, Dr. Rich Zweifler, I guess it was the organization just tapping the guy who kept asking questions about what more things we could do on the telemedicine front. And we had already started to do not only the cardiology that you mentioned, some nephrology programs, some non-stroke neurology. We had a tele-ICU that had been built. Telepsychiatry was starting to grow its roots. But from my perspective, I was fortunate to get exposed to this even when I was in medical school at the Medical College of Georgia with Dr. David Hess and the stroke program there. When I was at the University of Louisville, as you mentioned, with Dr. Carrie Remmel, Dr. Ray Dorsey, who's a titan in the digital health field, particularly as it relates to Parkinson's disease, was a co-resident of mine when I was at the University of Pennsylvania. So I think I've had some accidental mentorship along the way that's been really fortuitous and it's fun to be a part of.
And David, I got to say, you are the first neurologist I think we've met who's leading digital health at a health system. Was that accidental? Is there a reason why it makes sense for folks from neurology to be leading this charge? How did that happen?
Well, I think it's probably two things. One, neurologists are sometimes affectionately called nerdologists. So we're pretty good when it comes to digital capabilities and like to tinker with things. And so probably it's not surprising that most of the earliest telemedicine networks in this country have been telestroke first. And so I think it makes a lot of sense when you see other neurologists who are interested in this, I'm not alone in that respect. But I think the other feature there is that neurology, in fact, is the endpoint of a lot of the problems with chronic disease management. So hypertension, diabetes, hyperlipidemia, obesity, all of these things are making up the predominant vascular risk factors that we see. And along with causing heart attacks and heart failure, they're the ones that cause the strokes. And we know that poor vascular health is a risk factor for things like Alzheimer's disease. And so even a neurologist, even a Parkinson's disease doctor like myself, who takes care of an aging patient population, really began to appreciate the chances to meet patients where they are, to think differently, particularly with older patients or patients who aren't as mobile as some of the younger ones might be, to try to find ways to reach them and use technology to augment and complement that. So it's been a good fit for me, and I think there's more of us out there.
Well, hopefully after this episode, there will be as well. Should expand the reach. David, it's interesting.
I'll make some calls.
Yeah, exactly. It's interesting you mentioned, your work in neurology is around these patients that have built up a lifetime of, different circumstances that have maybe led them to where they are today. And in a video chronicling your day-to-day life that is available online, you shared your views. I thought this part was really interesting. You shared your views on why empathy is critical for all aspects of medicine, really because it builds that trust between a provider and its patient. And I think it's interesting as well, you mentioned you'd prefer to almost work with patients over their entire life, like a 15-year journey with them. And so I'm curious, how does that perspective play when you're taking a look at how digital can maybe really help your reach in these patients? How do your views on keeping with the patient over their lifetime shape the views that you have on where digital can help out in establishing these lifelong patient relationships?
Yeah, that's a great question. And if you look at even some recent surveys in the last 3 or 4 months have been published, there remains an undercurrent of concern amongst physicians and other practitioners about gaps in their ability to connect with a patient if they're relying more heavily on digital medicine or other telehealth connections. And I think on the surface, that may make sense that you have less personal touches as part of a more digital relationship. But in fact, I think there's some paradoxical benefits there. And there's similarly been publications, particularly in the psychiatry and other mental health literature, that indicate the same thing, that when you are connecting with a patient on their time, in their domain, where they are, not just physically, but also emotionally, mentally on their healthcare journey, it, in my opinion, and others have found the same thing, may be easier to become empathic. With sympathy, you feel for someone, but with empathy, you feel with them. And if you are with them, if you're making that virtual connection into their home, sort of like the old traditional house calls, where I'm seeing a patient sitting at their dining room table or sitting on their couch with their family around them, and I can see the gallery of family portraits behind them, and I can hear the dog barking in the background. I think that's actually a unique advantage to make that connection, because that patient has invited you into their home much differently than us inviting them into our clinic, which can feel significantly more sterile. And so I think uniquely, whether it be forward-facing episodic telemedicine care or what we do in our Ochsner Digital Medicine program with back channel chronic disease management, remote patient management, with things like digital coaching and personalized coaching, I think there's actually some unique advantages in new ways that we can create those empathic touches with our patients.
And David, actually, that's a great topic. We did want to dive a bit more into the work you're doing with the digital medicine program at Ochsner. And I think we were reading, you've done some great work on, I think it was hypertension and maternity care and other areas. Just for folks who are unfamiliar, could you share a bit more about the digital medicine program, what it is today, what use cases you're working on? And also, I'm also curious, how do you decide which use case to enter next?
Yeah, that's a great point. And I referenced our digital medicine program. So I began working on the telemedicine front, that sort of traditional forward-facing episodic care, like I mentioned back in 2016. And then at the end of 2019, just a stone's throw away from our first case of COVID-19, I took on an additional role working with my dyad partner, Julie Henry, she's the COO of our Ochsner Digital Medicine outfit. And the way that had grown within our organization was through our Innovation Ochsner Suite, our research and development wing that has been led by Dr. Rich Milani, a preventive cardiologist, Amy Court, Jonathan Wilt, other fantastic colleagues, to really build that new and different way of taking care of chronic diseases at home and to go beyond remote patient monitoring, but really get to the crux of management, where we realize that when things are working best, you have an engaged and personalized health coach to be shoulder to shoulder with a patient. You've got the right medicines being prescribed at the right time in the right circumstances with emphasis on compliance for the patients. And then lastly, you've got ongoing wheel of data that gets circulated between the patients and their care team, not just getting 2 or 3 blood pressures per year or the reported blood sugar measurements that only are accompanied by hemoglobin A1C for diabetes management a couple of times a year, but literally 30 or 40 times the amount of data being driven between patients and a care team so that we can be reactive and proactive to take care of those diseases. And so as those have grown in our organization, I wake up every day thinking of new ways that really we can merge them together, where we can use remote management along with episodic healthcare, telehealth care, and think about what that next step will be. You asked about how we decide sort of where we go from here. And I'm fortunate, even before I went to medical school, and I got my master's in public health and epidemiology at Emory, as you mentioned. I was able to work at the CDC and with a liaison to the World Health Organization named Dr. Brian McCarthy. He was a pediatrician and a clinical researcher. And as we were working together on new public health initiatives, and I was a spry kid right out of college, he taught me about the 5 A's, and there's been lots of A's that have been proposed over the years, but I use those A's almost every day with my team to think about what we're going to do, and happy to share them here. So the first A is appropriate. So should we be doing this? It's not just because we have a digital device that we could do something, but should we do it? Will it really offer something, at least right out of the gate, that we think a patient would do better from and that a provider would embrace? So is that an appropriate thing to do? Then we bundle 3 other A's. How is it going to be accessible? Meaning, what sort of digital tools do we use? How's it going to be available? Are the hours of operation, or are there limitations from a geographic perspective? And how can we make it affordable? We need to make it affordable to patients. We need to make it affordable to a healthcare organization. We need to make it affordable to the grander, $4.5 trillion healthcare spend in this country. And so once you get those together, then the 5th A is, will this be acceptable? And if you work hard on your other 4 A's and you're aligning your stakeholders all along the way, then 9 times out of 10, you come up with a product that is acceptable. It's the right thing to do. You've done your due diligence and you now feel like you're really onto something. One of my colleagues, Alice Arkello, just recently mentioned to me that we need a sixth A, and that's accelerate. And I think she's exactly right. How do we then get that product out there, not only in our own backyard for our patients, but even in a business model to be able to expand it nationally or internationally?
And when you think about that, it is Ochsner providing these digital medicine programs geographically beyond your typical face-to-face encounters? Like, have you gone like to multiple states that you otherwise wouldn't normally be serving?
Absolutely. We learned a lot about the value of what we call our Ochsner virtual provider network during the pandemic, early on, harnessing the advantages of some of the relaxation of licensure requirements, state-specific licensure requirement for physicians and other providers. We use that experience and the time afforded by it to get permanent licensure, multi-state licensure for many of our physicians. And we built a core of physicians, both in the urgent care space, in the neurology space for stroke and other non-stroke neurology, the psychiatric space, intensive care space, to have multiple states available as we continue to expand. Another way that we've now gone, and we're in all 50 states live, is with our digital medicine programs for diabetes and hypertension, partnering with payers, with other insurance brokers, large employers, even other health systems, to try to sort of spread the good word, if you will, about the advantages of, again, not just a health and wellness program or not just a remote patient monitoring program, but that soup to nuts management program in a focus factory that does medication management, does coaching, and really transfers the data seamlessly.
That's incredible. And actually, I'm not quite sure if I've heard of another health system who's provided that entire full stack of, let's say, virtual diabetes management. I mean, obviously there's certain, I think, some companies who've done it, but I think Ochsner might be the first that I've heard of that's actually delivered at that scale. So that's actually really phenomenal. Congratulations on that.
Thank you. And again, the most important thing that I've learned here, working as just a simple neurologist in the space, is to be able to work in a large health system that's now 80 years old, and really recognizing that having a forward-thinking, digitally connected, but traditional health system in its own mind, we think is the special sauce. There's lots of partnerships that we've forged with excellent third-party organizations, excellent tech companies, places that frankly can accelerate faster than we can in some respects, and certainly have the funding to do it through various funding rounds. But ultimately, at the end of the day, when there is already enormous trust for patients built into health systems that they've been around for years, or that they're even being introduced to for the first time, we think that we thread the needle by taking that digital approach within the four walls of a traditional healthcare system.
And I guess the other piece too is, as a health system, you have a history of having a very high bar for evidence-based medicine, for quality, for patient safety. And I think, we've seen, unfortunately, some cases in the recent past where some, private companies that don't have that history or that DNA of quality and evidence-based medicine have run into some trouble, let's call it, focusing more on margins than mission. But I guess as a health system, mission, margins are maybe a part of the journey to get to mission, but the mission is the most important thing. So I think that's probably standing out more in the recent past than ever before.
Yeah, I agree with you, Josh. I mean, I think ultimately the benefits of our academic group practice is that we strive to work towards a common purpose, and whether that be sort of wrapped up into the individual work of an individual physician at that moment, where they're seeing that patient with CHF in their clinic, or they're seeing that patient with dementia or lupus or cancer. But what really broadens that, and has been effective at broadening it, even from when the five founders of the Ochsner Clinic did their thing 80 years ago, has been a higher and greater purpose to take care of community. And as our community spread from New Orleans to the southern part of Louisiana, to the entire states, now across the Gulf South, it's actually been a fairly easy transition. Geography actually got in the way a lot more before there was digital health. And so we've learned a lot about the advantages of being able to spread our wings and take care of more patients that we think benefit from our care. But we've also been able to cut down on the windshield time now with the way that we use telemedicine and digital health.
Amazing.
That's great. So actually, David, I do want to rehash some old memories of yours. This is after launching the Ochsner's Care Connect 360. I think that's what it was coined back then. The platform in 2018, you participated in a Facebook Live, And you gave a whole bunch of great points on what the program's all about and what it's going to do to revolutionize care. But there was one part in there that I really thought was profound. You voiced your enthusiasm for the digital care and what it can do to the healthcare system, but then also your concerns around health disparities and why it's important to consider how digital could play an unintended role in further segmenting and siloing care if it wasn't implemented properly. And obviously that's extremely relevant today. So what can we do to proactively prevent this greater digital divide from occurring within our communities?
Yeah, it's a great question. And we are driven and most sensitive about some of our most traditional vulnerable patient populations, whether that be segmented by geography, urban versus rural, or race, or gender identity, age, payer groups, or others. There is an opportunity with every interaction that we have with a family to realize where they are. And as I mentioned earlier, what better way to sort of reach somebody where they are than being able to utilize technology, but also utilize the technology that's right for them. So we have to focus as much as we can on that which is most ubiquitous and as simple as possible. By the way, that's important for our healthcare providers too. We like simple. I'll tell you that from personal experience. But sometimes that means leveraging audio-only visits or two-way texting. Sometimes that means making sure that the Bluetooth connections are easy and there's extremely low bandwidth requirements for data sharing, particularly like we see with a lot of our digital medicine programs. Sometimes it means making sure that we do have expanded hours of operations, recognizing that now more than ever, many of our patients or their families work two jobs, work second or third shifts, and to be able to be available for them when they're most available to us is really critical. And the combinations of different telemedicine and digital health programs, I think, plug a lot of those holes really well. In my clinical work, we'll have extended hours in clinic. We'll do weekend clinics. But the reality is that those have been expanded much more simply by using the technology that we now have at our fingertips. And we've looked carefully across different groups in our region with a keen eye to look for ways that we're failing, the ways that we're not reaching some of our most vulnerable patient populations. And I'm proud to say that we've uncovered very few. And I'm also proud to say that we're at the head of a handful of initiatives in our organization to help create and maintain a healthier state of Louisiana. Our CEO, Warner Thomas, announced just over a year ago of a new initiative called 40 by 30. And what that means is that we strive to improve to 40th out of 50 in most metrics of general health as far as the country is concerned by 2030. Now, if you're one or two or even in the top 20 right now, no one would aspire to be 40th. But Louisiana is usually 49th, sometimes 50th. And so for us to be able to make that big swing in only a handful of years, when every other state's trying to improve also, shows that there is dedication and determination all the way from the executives that help lead our organization down to the physicians and other healthcare providers that are the boots on the ground to really do things differently. And if we don't have an eye on parity of care and we don't focus on vulnerable patient populations, we won't be successful in our 40 by 30 initiatives. That being said, I think we will be.
That's awesome. I love how you made an earlier point about needing to reach patients in the way in which they expect to be reached. And, there's no one size fits all intervention, even for digital. I think that's a really great point. I also wanted to ask you more about also the provider side in terms of, have you yet seen digital and more technology enabled opportunities at health systems like Ochsner be a recruiting mechanism yet? Like, are you seeing clinicians say, hey, I want to go to Ochsner and practice there because I want to have more digital in my practice and my work, whether it's with patients or even clinical workflows? Is that happening just yet, or are we not quite there as an industry?
We're there. And for us, we're seeing it sort of in two ways. One is we have some current and future mostly healthcare providers, physician, APP, social workers, et cetera, that are purposefully looking to come to us for the opportunity to do more digital work, more telemedicine work. Sometimes those are career shifts. Priorities changed during the pandemic. People realized that they either experience unique benefits to seeing patients via digital and other technology means, or they had other reasons in their personal life that they wanted to expand their career to that. And so that's been a win for us. There's been ways that we've been able to retain folks that had opportunities to move, and whether it be a spouse or other family needs to locate in a different place. But because of the mechanisms that we already had built even prior to the pandemic, they've been able to move seamlessly and continue to work in a digital fashion. And then we're also starting to see it in patients who are, in providers that are coming in just in a traditional bricks and mortar sense. These are millennials and starting to hire some Gen Zs in different ways. And you can be certain that their life experiences are a heck of a lot more digital than us Gen Xers were at one point. And for them, it's almost table stakes to get them in the front door, look at what their career path looks like, look at the ways that we can put their clinic schedule together. Right out of the gate, they want to know, what are my opportunities to see patients via telemedicine? And we say, your opportunities abound here. And it's an exciting time to try to build those types of networks for those providers.
How much has this kind of seeped into your academic curriculum? Are you, do you have residents who are doing a lot of digital care and telehealth now? Let's say for neurology, is that like a really common part of the curriculum at all? Or how does that kind of woven itself into things?
It's a great question. I can tell you a little bit about our journey with this. 4 or 5 years ago, as we were starting to ramp up, particularly our hospital-based telemedicine programs, I'd mentioned stroke, psychiatry, some other subspecialty work with cardiology, nephrology. We had our tele-ICU. We saw residents and fellows starting to trickle through those rotations, and we got in touch with a lot of our service lines, our independent residency and fellowship programs, and offered our assistance to sort of teach website manner and ways to understand the right ways to practice telehealth. At that point, we even kicked around the idea of creating at the GME level, at the graduate medical education level at Ochsner, which has hundreds of residents go through it, a telemedicine elective where they would just work outside the traditional clinic or whatever their traditional clinic was, whether it be neurology or infectious disease or oncology, and learn telemedicine. What happened so quickly between us thinking about that and it continuing to accelerate and become part of every service line's daily work is we didn't need to create that, because we blinked and every residency program started to get exposure to our residents along the way. So when somebody is in the neurology department, as you asked, I have a resident working with me in my movement disorder and Parkinson's clinic. I'll have a half day of virtual clinic and they sit in the room with me. And when we were all remote, we had the technology available that they could join as the third party, and they were in the background also. And so that style of hands-on, getting it in front of you way of learning sort of is the traditional way that all residencies are taught. And so it makes sense that it'd be no different for telemedicine. Our idea is to sort of spend a month learning what telemedicine is, fizzle before it could get started, and it was a good thing.
I guess probably it won't be long before we're going to see formal digital medicine fellowships pop up. Maybe you'll have one in a number of years at Ochsner, and it's going to be a very common thing, I think, for a lot of residents wanting to go into digital and clinical informatics sooner. And it's going to be really exciting to see how that changes over the next 10, 20 years. I
think you're right. And we look forward to being on the forefront of that as well.
That's great. So David, you've talked a little bit about how the explosion of digital medicine has really taken off, obviously, throughout the pandemic. Prior to COVID, I read Ochsner was doing roughly 300 televisits per month. And then once COVID hit, that number skyrocketed to like 27,000 per month, which is an insane growth rate. So was really curious, what were some of the major hurdles that you had to overcome to support that type of growth?
Well, the first thing that I learned then and there is, and while it sounds cliched, is that it truly took a village. To already have built, but then continue to strengthen relationships with IS and our Epic partners internally, our marketing groups, our patient experience team, the service line leaders that were front and center, what was happening in hospital medicine. Any hurdle that we encountered was much more easily overcome with a group thinking about it, and the comfort level to be able to get in front of a group and say, I'm not sure how we're going to figure this out. We need help, than to be strong but wrong and think that we could go it alone. And so early on, that was our best learnings when things were really, really rapidly changing in March and April of 2020. Recall that was right after Mardi Gras season then, and so along with the other major early outbreaks on the East and West Coast, here we were in the Gulf South undergoing the same outbreaks. But I can remember well, in fact, that week of Mardi Gras break, making phone calls back to the team saying, look, this COVID-19 thing's real and things coming. We're going to need to think about how we're going to use telemedicine, and we're going to use it wisely and early. And we quickly got together and came up with a three-pronged plan. How could telemedicine and digital programs help emergent needs, seeing patients in the ER, seeing patients that were being admitted to the hospital? How could they take care of urgent needs? That was that wide berth of patients who thought they might be infected or who needed more information or needed to be screened, needed to be tested at our urgent cares and primary care slots. And what could we do chronically? What were we going to do when the world shut down to make sure that our diabetic patients were still following their appropriate diets and medications and keeping their chronic diseases under control, hypertension, high cholesterol? What were our cancer patients going to be doing to make sure that they got their chemotherapies at home? So we really bracketed everything that we did in the emergent, urgent, and chronic care buckets. And then as we walked through it, and we had a challenge, we overcame it. One unique story that I like to tell is some early and late nights on the hospital medicine units when we had dozens of iPads that we had available to be deployed into the hospital for doing telemedicine right then and there from between two walls in an ICU or on the regular floor. And the purpose there, of course, to keep the patient safest and the respiratory therapist safe and the physician safe. But you know what we didn't have? We didn't have iPad holders. And so we have a 3D printing outfit, and we ran those 3D printers all night, printing out different covers and cases that would fit the iPads. And that, with a few zip ties and some IV poles, made a lot of telemedicine carts on a stick in about 48 hours. And so that was the type of ingenuity that I know almost every health system across the country went through, but it was certainly gratifying to see our crew always jump in and be able to come up with a new solution for whatever problem there was that day.
That's awesome. I think it goes to show just how ready you are to take on anything that needs to be done. So, a good example of that, I was reading through, we're talking about these staff shortages that are happening today. And I think it was an estimate last year of maybe 6,000 nursing jobs that were open at Ochsner. And, I read you actually went and did some additional training to help out with all these different things. So taking blood draws and using catheters, et cetera, taking off the white coat, to speak. And so I really respect not only your ability to adapt and overcome to some of these challenges when it came to, this explosion of digital, but just wherever the help is needed, you really step up to the plate. And, regardless of the title that you have, it's your responsibility to take care of these patients. And I just think that's really admirable. Kudos on that. But I'm curious on that front, is there an update on that situation regarding staff shortages, and how has that experienced over the last 2 years really shaped how you think about leadership?
Well, you're kind to bring up that story. And I was just a small part of a big need. I think there was many physicians across the organization that did different things in different times. Dr. Armin Schubert, one of our senior anesthesiologists, sort of came up with this idea. It was during the second wave, one of the second or third wave, when early on in the first waves, we had doctor shortages. And so we had lots of non-ICU physicians and others taking other shifts. And then with the next waves, we had a lot of nursing shortages, and we had doctors that were available to do that stuff. Now, I'll tell you, doctors make pretty lousy nurses in general, myself included. And so it was humbling and yet not at all surprising when I got there. And for a couple of shifts, they were kind. They were easy on us compared to what their jobs are. They got the hardest job in the hospital. I was proud to have gotten an IV on a first try. I was proud to help out with bathing patients and getting them ice chips, and I really enjoyed using the Pyxis machine. That's the thing that automatically dispenses the medications. I think most of us physicians were in awe of that. And we got a lot of eye rolls from the nurses. They see it every day. The good news is that we are not in the same place right now, either with this pandemic or hopefully any others to come anytime soon, to have physicians play nurse. That being said, I think it did two really important things. One, it really galvanized an organization to sort of reiterate that motto of, any port in a storm. And for us, who have weathered a lot of storms, many of them literal storms. We're right in Hurricane Alley down here. There's always examples of where people who not only work at the top of their license, but are absolutely willing to work at any license when you get in a jam. And so, one, it really galvanized that. Two, I think it did give us a heads up about thinking differently about the ways that we could support those sorts of things in the future. And so, we have continued to build virtual nursing types of products in our organization in different ways that we can offload some of the bedside nursing needs, reduce length of stay for patients, and put them in different settings in our hospital system where they will do best with more digital monitoring and maybe less human capital right there at the immediate bedside. So all of these experiences of my other colleagues shedding our white coats reminded us that to have a nurse connect virtually is probably better than have a doctor be there in person. And so the reality is that we can continue to build those things, and it'll work better for everybody.
That's great.
I just say I'm impressed, David, that you were able to get an IV right on the first try. I remember when I rotated through anesthesia, I had a lot of failed IVs, and probably why I didn't end up getting to anesthesia. So
I take a lot of pride in that, John. So when I was a resident, I was for a while, I was the guy, if you need to get a blood draw in the middle of the night, we didn't have phlebotomy teams back in the dark ages of residency for me. And so Houghton was someone they could call if they needed to get an IV or get a stick. I was well out of practice, I'll tell you that. And there were plenty of other things that I was not as good at. And so, but happy that I could draw a clean stick.
Well, now that not that the audience has heard it, you might get more calls soon. So
That's right.
And I guess, David, maybe want to touch a bit on somewhere else where you said, healthcare technologies allowed your patients to take a more active role in their care. So there's this huge, I wouldn't say new, but at least from a digital point of view, relatively new paradigm of digital patient empowerment and patients being partners in their own care. When you think about the next couple years of digital health transformation, what are the types of digital patient empowered opportunities that you're most excited about?
Yeah, I love this part of the story. And it's one that really effectively stretches across a lot of the work we're doing, whether we're measuring patient activation as part of our digital medicine programs, whether we're measuring net promoter scores from our patients that talks about how much they appreciate the program and how much they would recommend it to somebody else. To actually, your point earlier about healthcare parity and vulnerable patient populations. We, at the height of the pandemic, made a decision to expand our digital medicine program to our Medicaid patient population in the state, and that was a no-brainer from a right thing to do perspective, but it was a financial obligation for us to do, because in the state of Louisiana, Medicaid does not have the usual payer mechanisms to cover remote patient monitoring. And as I've said earlier, our management program really doesn't fit well into the CMS remote patient monitoring codes anyway. So we were able to leverage 2 rounds, fortunately, of grant funding from the FCC, $2 million total that we're able to use part of to cover the costs of glucometers and blood pressure monitors and other supplies, to, in a compliant fashion, send to our patients as part of our Medicaid population, and enroll them with a cost of $0 to them in the program. And what we appreciated was a handful of things. One, we were very purposeful in rendering our program identically for Medicaid patient populations, as we've done for Medicare, as we've done for commercial, as we've done for young, for old, for urban, for rural, because it works. It works the way it's designed, and to do anything different, more than anything else, I think would imply some bias on our part to think that certain patient populations wouldn't benefit. And in fact, it proved to us once again that our Medicaid patient population responded beautifully within our program, particularly with the financial assistance that was rendered by the FCC funding. We targeted 1,000 patients. We now have more than 4,000 patients in the program. But the other thing, and this sort of gets us back to the discussion about the active role in their care, both anecdotally and objectively, this particular, I would argue, in many respects, previously marginalized patient population within the friendly confines of traditional healthcare, were even more empowered, more engaged. And I mentioned our Net Promoter Score, which sits at around 87 for our overall program. Our Net Promoter Score for our Medicaid patient population is 91.
Wow.
And that gives me a warm feeling inside every time I say it, because I think that's just a remarkable testament to the great team that we have put together that reaches patients. This is a digital program, but the real reason for its success is the process and the people. And to have those people work shoulder to shoulder with our patients. We've had our health coaches get invited to weddings of their patients. I mean, this is a digital program, and we're getting people on the other side of that digital divide that have become really close confidants of the patients they take care of. And so I think it goes all the way back to, maybe it was my first point about meeting the patients on their time, in their space, and they are motivated to do it. If you manage that correctly, you will reap all the benefits that you're expecting to see down the line, from a Net Promoter Score perspective, from a blood pressure management perspective, from a patient satisfaction and activation perspective, because you have shown them that you respect how busy and how purposeful their lives are, that you're going to reach into theirs rather than requesting or requiring that they come into yours.
It's fascinating that you're using the Net Promoter Score for your digital program. I was wondering, are you also collecting NPS for any of your traditional care programs, or is that something you're only doing right now in the digital world?
We're halfway into that story. So, we had been using it, I would say, sort of in a forward thinking, again, from Dr. Milani and others early on, because we figured our peer groups for digital medicine aren't going to be traditional healthcare plans and traditional hospitals. We want to make sure that our digital medicine program is as comfortable to somebody as Instacart and Amazon and others. And so we wanted to sort of speak their language and compare ourselves that way. As a result of that, and I think just a general direction that the industry is going to look at how patients appreciate something that they're using, we're starting to test now NPS across a lot of our other products. So when you have me back next time, I'll give you some updates on how our NPS sits for some other things within our health system.
That's great. And actually, just to put it into context for people, you mentioned the average NPS that you're having with the digital program is 87. and 91 with the Medicaid patients. 87.5 is higher than Amazon's NPS, higher than Apple's NPS, higher than Uber's NPS. Like it's a phenomenal score. So just need,
Thank you.
I needed
Thanks
to
for
shed some light
noticing.
on
We
that.
appreciate
Yeah. That's great. Well, Josh, did you have anything else? Otherwise, we can jump over to the Fast Five.
Let's do it. Let's jump over.
Awesome. Okay, so David, Fast Five is basically 5 questions to get to know you better for our audience. First question we have is, what is your favorite book or book you've gifted the most?
Okay, so my favorite book of all time is The Catcher in the Rye by J.D. Salinger, and I read it for the first time in high school. It was gifted to me by my grandmother, who was a high school literature teacher, and I remember well, written inside the book jacket, Dear David, my students particularly loved this book when it was banned by the local school board. Love, and so I think I probably appreciated it for the first time because I felt somewhat scandalous as a 15-year-old reading about Holden Caulfield, and I don't know that I necessarily relate to him as the protagonist of the story, but still a great read. So and I think part of the canon of literature. I will say that I am now reading, and in fact, I have it right here in front of me. It may not show up well with the blur. Leading with Gratitude, which is I am really enjoying it. We've got a small group of us that work here together. Julie Henry, who I'd mentioned, my dyad partner in digital health, and Denise Bazo, our new chief digital officer. We are all really focused on gratitude and particularly sort of weathering the pandemic and now coming out on the other side of it, we hope. Just to be so thankful of the chances that we've had to work with great people and continue to ride that wave. And so I think I'm really enjoying the book. I've already given another copy to a colleague. Haven't even finished it myself yet, but Leading with Gratitude seems like a winner right now.
Oh, that's awesome. I love that. Question 2 is, this one is specific for you, David, but I know that before getting into medicine, you had at least entertained the idea of possibly becoming a cartoonist. And so I'm just curious, are you still doodling and drawing, or is that something in the past now?
I should probably show some examples of that too on the desk, right? So I can't, it's probably a running joke amongst my colleagues here, is that I can't not scribble something. It's mostly flowcharts and Venn diagrams and arrows and asterisks and all sorts of other gobbledygook now, rather than Garfield, which I learned to draw for the first time when I was a kid. But I find that's a pretty good way to keep my mind focused, and always has been. So I'm a very visual learner. And so when I took notes in high school and college, I'd be doodling little things on the side to help me remember it. And it stuck with me. So and there's actually a lot of, when I learned neuroanatomy, not to imply that I know everything about neuroanatomy, but when I learned it and studied it as part of being a neurologist, neuroanatomy is very algorithmic, right? A leads to B, leads to C, leads to D, and that was almost all drawing for me, to be able to draw these different neural pathways in the human body. And so I guess fortuitous that my intent to become a cartoonist when I was in grade school somehow made its way into medicine, and now telemedicine and digital health, but I still like to doodle.
Whenever you're doing academic presentations or conference presentations, you should probably just do all your slides and doodle. Like, I don't think anyone's done that yet. You should do that.
all stick figures and
yeah, exactly.
let me write that down.
That's great. Question 3, David, would you rather have super strength, super speed, or the ability to read people's minds?
Ooh, super strength, super speed, or read people's minds. So I have two boys who are in middle school. My oldest son is graduating from 8th grade tomorrow, so he's moving into high school, and my other son's going into 8th grade next year. And these are the types of good sort of superhero conversations that you have with middle school boys. So it was super strength, super speed, and ability to read people's minds. So I don't want to read people's minds. I don't think I have enough confidence to want to know exactly what people are always thinking about me or someone else around them. So I think ignorance is bliss from that perspective. So I don't want to read other people's minds. Speed versus strength. So I think speed. I think maybe that makes sense in telemedicine too. Better to be able to get to an endpoint and have a say to do ratio that's high because you're fast to make decisions and fast to accomplish things rather than just brute force to beat it over people's heads. I've probably learned that amongst my physician colleagues too, is be fast with an answer and make sure it works. Don't try to ram it down someone's throat. So super speed.
Yeah, I love it. Awesome. And question 4, what is something in healthcare you believe that others might find insane?
So meaning other non-clinicians, like something that's sort of like, what's a trade secret?
Yeah, it could be that, or it could even be other clinicians that, have a completely different perspective than you do.
Oh, okay. That's interesting. Okay. All right. So I'm going to answer it like what's something that's probably common in healthcare that maybe people outside of healthcare don't know. And this is, I know that this podcast will be listened to and watched far and wide. So I guess I won't be able to deny this, but doctors Google things. We do. And sometimes it's because we don't remember what we think we wanted to remember right there in that moment. And a lot of times it's because we want to put ourselves in the shoes of our patients. Mm-hmm. So if I know that my patients are Googling cure for Parkinson's disease, which I tell you they are almost every day, it behooves me to Google what's a good cure for Parkinson's disease, even though I know darn well we don't have one yet, because that's what our patients are doing. And they're going to read that stuff. And you need to be able to understand what's out there. So I think the combinations of understanding what's out there in the sort of the lay literature to keep in touch with that sort of whole theme today of making connections with your patients is important. And sometimes Dr. Google's right. So we Google things.
That's great. That's a really valuable insight. I've never thought about it from the empathetic lens of actually understanding, what kind of snake oil is being pushed out there, and how do you, figure that out? That's great. The last question that we have is more of a pandemic lockdown related question, but what is one hobby or activity you've gotten into since the beginning of the pandemic?
And have been able to maintain, right?
Sure, yeah. Yeah, not one that you took on for a week.
Right, so like all of us, I'm gonna bike to work every day. All right, so I've gotten into backyard birds a bit, and I am no birder by any stretch of the imagination. I shouldn't even call myself a bird watcher for the most part, but I enjoy sort of piddling around the yard. I like to sort of see the immediate benefits of trimming something or hanging something. And so I hung a bunch of bird feeders periodically, and I'd find another bird feeder on sale somewhere. So now backyard's a handful of bird feeders. And I started to appreciate the birds that would come through and sort of the personalities of them. So like, we have a few blue jays. Blue jays are coming down here, and they're the ones who have the super strength. I think the blue jays come in and sort of assert themselves. And then we've got these little thrushes and brown sparrows and others that they're sort of the super speed. Maybe they zip in and zip out, and then we have squirrels. And so I've, along with being infatuated with sort of the birds that have found, we have two cardinal families. We have two male and female cardinals that seem to have found each other for life. And they're separate, but they have their own lives in our backyard. But we've got squirrels, and so I have not yet been able to outwit any of the New Orleans squirrel population, be it with different squirrel-proof.
Yeah, the grease on the poles, or
I don't need poles. I haven't sort of bolted into fences and whatnot, and trees. And so I frankly, I've given the squirrels a bit of an advantage, and maybe deep down I'm sort of okay to watch them cohabitate with my birds. But it's still fun. I've become, that crusty old neighbor that, get out of my yard, squirrels. But maybe I do like them there anyway.
That's amazing. David, I have to ask, have you talked with Denise Bassau about birding?
Not enough.
Okay.
Not enough. I understand that she has a little bit of experience in the same. So Denise, I'm glad you mentioned her. I mentioned her a few minutes ago. She she's probably on like day 150 here or something. She has not been long with our organization. I hope she will be here forever. She's been, a remarkable addition, came in with clarity of thought, a dynamic strategy, and an all-around terrific leader. But probably some culture shock for her coming down to New Orleans. And I know that you had a chance to have her on the podcast as well. Did she?
We did. She brought up birding, which is why.
Yeah, I want to ask you: is there a birding club at Ochsner, or because you both had the same answer? So.
It sounds like there may be a club of two now. She was first, so I guess she'll be the president, and I'll be the vice president of the digital medicine birding club.
That's right.
Well, someone else mentioned birding too. So I think birding's actually the lead, right, Alan? It might have the most.
Yeah, I think 3 people have now said birding. Yeah.
I even went so far as to buy the North American bird guide that I keep right next to it. Although admittedly, again, I haven't recognized enough of them. I'm not so sure that I have a terrific variety of birds that show up in my backyard in New Orleans, but the ones that are there are really, really lovely.
Oh, that's cool. I like the idea of, taking a look at the ordinary things around you, but appreciating them in a different light. And it really took the pandemic to get us all to kind of slow down and recognize that. Well, David, I'm just looking at the time. I know we said we keep this short in the hour. So I just, being mindful of your time, we should head out. But I wanted to thank you very much for coming on the show today. You've shared a ton of wisdom with us. You mentioned that our Fast 5 question had one of them that middle school boys would ask. So we really appreciate that. But no, in all honesty, you really did share a lot of great stuff with our audience today. And I learned a lot, and I hope they did as well. So I just wanted to say thank you again. You can also find David on Twitter at David_Houghton. That's HOUGHTON. And that's a wrap for this episode of The Digital Patient, hosted by Seamless MD. You can follow us on Twitter at Seamless MD. And if you like the podcast and you want to learn more, visit www.seamless.md. Thanks, David, so much.
Thanks, David.
Thanks, guys. I appreciate it.